Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties. I am Arjun Gupta, a fellow with Costs of Care, and I'll be moderating today's webinar. Today, we will share innovations in engaging some of our ancillary medical services, namely speech and language pathologists and audiologists. Our expert guests today are Daneen Sekoni, who is the Director of Healthcare Reform Policy at the American Speech, Language, and Hearing Association, or ASHA, and Martin Brodsky, who is a faculty member in the Department of Physical Medicine and Rehab at Johns Hopkins University. Welcome, both of you.
Thank you.
Thank you.
So Daneen, could you tell us a little bit about ASHA, what services it covers, and how these services can broadly add value?
Certainly. So the American Speech Language Hearing Association is the national professional, scientific, and credentialing association of more than 198,000 members and affiliates who are audiologists, speech language pathologists, speech language and hearing scientists, audiology and speech language pathology support personnel, and students. Audiologists are experts in providing treatment of services for patients related to the prevention, diagnosis, or treatment of hearing, balance, and tinnitus disorders. Hearing impairments are often related to medical conditions such as diabetes, ototoxic medications, chronic renal disease, and hypothyroidism. Speech language pathologists identify, assess, evaluate, and diagnose speech language disorders such as stuttering, swallowing deficits, and cognitive disorders. These impairments can be related to stroke, traumatic brain injury, Parkinson's disease, multiple sclerosis, autism spectrum disorder, and others. So what I always like to say when I think about audiologists and speech language pathologists, I consider them as healthcare professionals that help individuals communicate. This is the communication profession. If individuals can't communicate, how can they participate in life? So I look at speech language pathologists and audiologists providing value in the quality of life of individuals they serve and helping them more meaningfully engage and interact with their communities, their families, and in the workplace.
That's very well explained. And so Martin, could you tell us about some of the specific initiatives that maybe you've led or you've been involved in how speech and language pathology has actually helped patients more directly?
Absolutely. So one of the initiatives as a speech language pathologist that we also do, in addition to speech, language, and voice, is swallowing. And what I'm involved in over the past couple years and few years are interventions related to patients in the ICU, as well as one excursion that I had with a colleague here at Johns Hopkins, as well as another colleague at New York University, where we went to Puerto Rico to teach them how to do swallowing screenings on their stroke unit. So we basically take the show on the road, as well as practice in our own hospital the screenings that are out in evidence-based literature.
So how would this work for someone who's maybe not familiar with this literature? We know that patients who are intubated or who undergo mechanical ventilation have high rates of swallowing difficulties and aspiration post-extubation. So suppose we're at a community hospital who's trying to prevent these rates of aspiration pneumonia or aspiration following extubation. How do they go about screening these patients, identifying them, and making sure that this doesn't happen?
So there are a number of screenings that are available in the literature. In the most cases in most hospitals, speech language pathologists are quite well versed in knowing which screenings are most appropriate with any given patient population. In addition to the speech language pathologists actually evaluating patients, they have trained and have been involved with initiatives in many places with nursing and nursing staff for assisting the nurses with screening patients to determine which patients in fact are appropriate for referral to a speech-language pathologist for further intervention.
Perfect, and it's all well and good for a place like Hopkins, which probably has a very supportive leadership group and has lots of resources. How about a community hospital, 400 miles away, which has a 6-bed ICU and no sort of value culture or no sort of trained professionals or speech and language pathologists? How can these people initiate such programs? Is there specific training that they can undergo? Or how do they learn these skills? And maybe, Daneen, you can answer this question as well.
So I think probably one of the best steps is to reach out to a local speech-language pathologist if there isn't one in that particular hospital. Alternatively, of course, ASHA is a wealth of resources, and reaching out to them, they can put you in touch with speech-language pathologists in the close area that might be able to assist. Alternatively, anybody watching this video is certainly welcome to email me, and I'm very happy to point you in the right direction, if not outright do the training myself. The idea here is that we're trying to prevent all of the difficulties and comorbidities that might come with patients who actually have swallowing disorders. So it's pretty important that we get to these folks and we get to them pretty quickly within the hospital stay.
Yeah, so just to piggyback on what Dr. Brodsky said, if individuals are interested in identifying a speech-language pathologist in their community, certainly visit ASHA's website, www.asha.org/profind/ and you can find a speech-language pathologist in your area.
And from what I understand, Martin, is that most of these trainings are fairly simple, maybe take just a day and don't require much equipment. Is that right?
That's exactly right. You don't need any particular background to be able to participate in a seminar related to screening. All of that would be given by the person who would be giving the training. So as long as you have people who are interested and people who are capable of approaching patients, those are the only prerequisites. Ideally, we'd like to speak with the champions of the units or of the hospitals so that they can, in turn, once we train those individuals, train others. So effectively, they become the super users, if you will, of the swallow screening, and then they can train the others and multiply going forward.
So could I share an example of a swallowing assessment screen for swallowing screening post-stroke? Is this a good time to just add Absolutely. A little bit to the conversation? Okay, great. So there are opportunities for physicians in the community or in the hospital to incorporate a swallowing screen and assessment in their protocol. In the community, for example, when a stroke survivor presents to the primary care physician's office in the community, some good triggers that the physician could consider when thinking about there's a swallowing assessment or a swallowing difficulty rather includes, does the patient have medication noncompliance? Does the patient have difficulty swallowing their medication? Is the patient oftentimes having difficulty with feeding, such as swallowing food or eating? Are they coughing often during meals? Are there changes in the hydration patterns or the dietary or nutrition patterns? Are there changes in cognition that impact swallow while feeding? And this is particularly important for individuals who are living alone in the community. So these are some things for physicians in the community to consider when they want to decide whether or not they want to do a swallow screening and if a referral to a speech-language pathologist is appropriate for a more comprehensive swallowing assessment. Now, in the hospital setting, for example, if a hospital doesn't have a more routine swallow screening assessment protocol set up, there are some options that hospitals could include. For example, you could have a speech language pathologist train nursing staff to perform the screenings. And if they identify a swallowing deficit, they could refer that patient to a speech language pathologist for a more comprehensive swallowing assessment. Alternatively, you could have the physician incorporate in his or her medical evaluation a swallowing screen. And again, if they identify any swallowing problems, they can refer to the SLP. Another option is that the physician, the nursing staff could just refer all patients presenting with certain conditions, like if they're in the acute stroke unit or if they're presenting with specific diagnoses, to a speech language pathologist for screenings and assessments. And finally, you could have your nursing staff reach out to a speech language pathologist on an on-call basis, particularly if a patient presents to the ER with certain symptoms, or conditions that could pose a risk of dysphagia. So basically, the main takeaway we want to import or share with the listeners is that, you know, if there's a patient that presents during the swallowing screen that may have some swallowing difficulties, it's really important that that patient is referred for a comprehensive swallowing assessment. And typically, when that patient is awaiting the further assessment, there can be precautions in place, such as no oral intake, or there could be precautions on the diet and what they are allowed to eat or not eat.
One of the things that makes this very important, in fact, is that on Medicare's hit list for the 30-day recidivism and hospital reimbursements is aspiration pneumonia. So we want to, certainly we're looking out for the best of the patient from a health and beneficial standpoint, but from a fiscal standpoint, we certainly don't want readmission within the next 30 days after hospital discharge. And coming back with an aspiration pneumonia at any time is a no-no. So we want to take the precautions to be able to avoid those kinds of situations.
Perfect. So I'm getting the sense that early identification, screening of high-risk patients, especially say post-extubation or stroke patients, is very, very important. And I'm assuming that's also because we have good therapies for these conditions. So early identification has to be followed by therapy. And I'm assuming a lot of these are just exercises or something that they do maybe with a few trained sessions followed by practicing on their own. Can you tell us a little bit about how that usually happens or how long that needs to go on?
Sure. It depends very largely on what the evaluation shows. For those who screen and pass the screening, largely no treatment, of course, is necessary for those individuals. For those who don't pass the screening, a more formal bedside evaluation or clinical evaluation is completed by a speech language pathologist. At that point, they make a final decision, if you will, between feeding the patient, beginning oral feedings, or going on with an instrumental evaluation to determine what physiologically is the difficulty that the patient is having. That instrumental evaluation, whether it's an endoscopic evaluation, sometimes referred to as FEES, or fiber optic endoscopic evaluation of swallowing, or a videofluoroscopic evaluation of swallowing, and it goes by many names, whether it's MBS for modified barium swallow, or videofluoroscopic swallow study. Those are the two big ones. Those two evaluations will be able to point out physiologically what's wrong with the patient. Then targeted treatments to improve the physiology of the swallow is what ultimately comes from those instrumental exams. In addition to that, of course, recommendations for how food should be most safely taken in, and whether it's oral or non-oral. And if it's oral, what the consistency of the food is that's best able to be tolerated by the patient safely. And by that I mean safely without the risk, or at least reduced risk, of aspiration. So once the physiology has been determined, there are many exercises and therapeutic techniques that we can use to introduce to the patient, to teach the patient, and many of them have very quick fixes. For example, a postural change or a maneuver during swallowing can immediately rid the patient of aspiration and very sincerely reduce the risk of aspiration. But that's not going to rehabilitate the swallow. They still need exercises to be able to do that. Of course, the best swallowing exercise is swallowing in and of itself. So we want to at least try and push the oral diet as best as we can to maintain the same physiology, to maintain the same muscle movements and structural movements that would ordinarily take place. If there is weakness in the system, there are exercises to address that. So as a very last resort, making a patient non-oral is an option, but most patients can probably get away with at least something to eat orally. And that's really the goal. We want to keep them eating, keep them well hydrated, keep them with oral nutrition.
Perfect. So my main takeaways from today's webinar is that, as Daneen said up front, is that speech and language pathology and swallowing is more about communication. And when we talk about healthcare value and applying the Porter equation of outcomes that really matter to patients over costs, I'm sure that most patients would like to communicate and also be able to swallow. And if we add the added benefit of avoiding complications such as aspiration pneumonia, I think that's a very solid argument for having these speech and language pathologists available at almost all of our facilities, especially facilities that are seeing a lot of patients who are extubated or who are seeing a lot of stroke patients. The upfront cost of having these specialists might be something to consider, but basically the training or these individuals are not too expensive to get on board. And then we're talking about reduced penalties to Medicare for readmissions for these patients. So I think this is a very easy way to add value for our patients and to the healthcare system. Anything else you would like to add?
I can actually add a little bit to what you just said. To give you some idea as to what the cost benefit is, a speech-language pathologist, approximately an hour's worth of their time is a few $100s. The admission of an aspiration pneumonia with no other comorbidity to treat is about $25,000 to $30,000. So it makes sense to do the screening and makes sense to get the speech-language pathologist involved early to avoid that complication.
And I would just like to add, again, please visit ASHA's website. We have a great FAQ on swallowing screening that I would encourage everyone to take a look at. You can again go to our website, www.asha.org, and you can hit the search button and type in FAQ on swallowing screening. Feel free to take a look and download the document.
All right, that's all the time we have today. Thank you so much to the both of you for joining, and thank you to all of you for tuning in. We'll see you next month.
Thank you.